Sure. So we're glad that this topic is coming up, that this is finally getting the attention. So we know that when patients get diagnosed with cancer, let's say in this case multiple myeloma, we expect that all of these clinical trials that we talk about, that we are able to give the best treatment to every patient. In other words, also the right treatment to the right patient at the right time. And the only way we can translate the benefit of these clinical trials to each and every patient is when we are able to make sure that every patient gets the basic minimum best possible care. But with multiple myeloma, we have now noticed over the past few years that that's unfortunately not the case. And there are several layers of disparities in myeloma care. Disparities across different countries, disparities within a country between, let's say, the rural areas and the urban areas, and also disparities, unfortunately, dependent on patients' race and ethnicity, whether they are in urban, whether they are in metropolitan areas, whether they have access to academic centers or not. So a lot of data has been coming out showing us that the care we provide to our multiple myeloma patients is not necessarily the same, and unfortunately that leads to different outcomes. So for example, talking about racial disparities, there has been a lot of work done within the US looking at different racial ethnic groups, namely whites, blacks, Hispanics, Asians, and with the changing demographic landscape of the country, it's important to figure out, is the care being provided the same or not? So there are differences in disease between these groups. For example, Hispanics are much younger, African Americans are younger, whites are older. African Americans have lower incidence of high-risk disease, so their disease is less aggressive. African Americans present with less fractures, but they present with most anemia, most kidney failure, most calcium problems, for example, in myeloma. And then on top of that, even if we control for insurance status and morbidities, we know that minorities, racial ethnic minorities, get access to newer drugs, the benchmark drugs for myeloma, much later and to a much lower number. Also, stem cell transplant, a very, very important treatment modality for myeloma. While we know that the utilization of transplant in Europe is much better, in the US, it's not as much as seen in Europe. In African countries, in Asia, even lower. So within the US, African Americans or minorities get access to transplant much less frequently. And part of this is related to the fact that either the survival of minorities is inferior, or the survival of certain minorities, for example, African Americans, I mentioned that they don't have that aggressive disease, so they are supposed to have a better outcome, but they don't have that much of a benefit because they don't get the right treatment at the right time. The one thing that has been very reassuring, though, is that now there are about 3 or 4 large studies or data analyses looking at the fact that as long as the patients get the same treatment, get appropriate treatment, their outcomes are the same. So we did a large analysis out of almost 10 years worth of clinical trials in the US, national clinical trials, showing that when African Americans, Hispanics, whites, when they get the same treatment on clinical trials, their outcomes are the same. They have the same amount of disease control and their survival is similar. So the bottom line is we need to really try our best to get the appropriate care to the patients across the board, and if we feel that there are barriers to that access, we need to try and overcome those barriers.